Yeah, Rob, you better get a little bit more on top of your nonsense here, my man. All right, let's start with ears, eyes, nose, and throat. Mostly because there's not many things that I think that we really do in terms of fixing the ears, eyes, nose, and throat, except for eyes. We can irrigate those. Throat, I think personally, kind of falls more into the airway section because that's where the majority of your complications will really arise. But there's some other fun things that could pop up. So, eyeballs. General ideas of conditions of the eyes, right? Because sometimes people call 911 for things that they really should just go to the urgent care for. Conjunctivitis, aka pink eye, right? It's either a bacterial or viral infection of the eye, very contagious. Sometimes it's caused by an allergen or some other foreign body that's kind of lodged itself into your eye. This is super common in kids. I had pink eye like four years ago. I ended up with like a double pink eye, a sinus infection, and an ear infection. And I woke up and I'm like, I'm going to work. And my husband's like, you can't. You look contagious. I'm like, no, I'm fine. So I call my boss. I'm like, hey, I have pink eye. He goes, please don't come to work. So that was like the only time I think I've ever called out sick and was actually legitimately sick. So kind of common. You get a little of the pus. The little eyeball, usually you wake up with it and you're like eyeballs glued together from the crusties. What are we going to do for it? Nothing. We are not going to touch it. One thing that they do always check if you go to the doctor, or usually check if you go to the doctor with pink eye, is to make sure that the patient does not have a corneal abrasion, which is a scrape on the cornea of the eye. Again, this is commonly caused by like a foreign body under the eyelid. It feels like, when you get an eyelash in your eye and you feel it just irritating the eye, that is kind of what a corneal abrasion may feel like. What they do is they put this really cool glow-in-the-dark stuff in your eye. It gets stuck in the corneal abrasion, and they hit you with the blue light, and if they see pretty much what you see here, then you have a corneal abrasion and not necessarily pink eye. Though you could have two for one, because sometimes it's fun for that coupon. A foreign body, any number of items that don't belong in the eye that are inside of an eyeball. These are one of those things that we can irrigate. We also, yes. Am I? Yeah. Womp. All right, so that we'll start over. We will start all over. Y'all just sitting there like, let me not share a screen. Thanks. Alright, here. I'll just show you the really good eyeballs. Conjunctivitis, pink eye, corneal abrasion. They throw up the glow-in-the-dark stuff, and then they hit you with the blue light. And if there's an abrasion, it glows. Foreign bodies in the eyeball. We irrigate, right? Some people have mastered the craft of spiking a liter bag, attaching a nasal cannula to the end of the drop set, and then using the nasal cannula to go over the bridge of the nose and irrigate both eyes. Super effective. We also have in our drug kit tetracaine, which can be used, or propanocaine, to help alleviate the pain of a foreign body in the eye or a corneal abrasion, etc. I think everyone's probably had a sty at one point or another in the eye. It's like this small pimple, essentially, right on the edge of the eyelid, caused by a blockage of a pore or sometimes a gland or a tear duct. Usually goes away on its own. Put a little hot compress on it. If it's infected, it's a sty. If it's not infected, it's a chalazion. Eyeballs. One of the things that we learned about is the glaucoma. So glaucoma is a increase of the aqueous humor in the inside the eyeball. And as that aqueous humor starts to build up, it puts pressure on the optic nerve. There are a number of medications, where glaucoma is a contraindication because it has the potential of increasing the pressure in the eye. I don't remember the names of them off the top of my head, but there are a number of emergency medications where glaucoma could be a relative contraindication. Relative meaning life over limb, right? If you're in a severe state of unwell, sometimes it might be worth the risk of giving that patient that medication, even though it might exacerbate their glaucoma. Usually because of the pressure in the eye, they start to lose peripheral vision, and it might be kind of subtle at first, where people don't necessarily notice that they're losing that, and then it gets worse and worse until they only have like very middle part of the vision available. Other problems with it can cause, just like when you have a patient who has really high blood pressure, where they have a headache and vomiting and blurred vision, you can have the same thing if the pressure is elevated just in the eyes themselves, because it does put pressure on the nerve and it sends a feedback to the brain similar to that of very high blood pressure. Iritis, inflammation of the iris, can cause blindness. Again, reddened eye. It can be very painful. Like, it's also hard to tell sometimes because you might have like a red bloodshot eye after a night of hard drinking, or it could be due to inflammation or infection. So, usually the idea is that if it is a persistent issue that you really should go to the doctor, but I'm going to say that, and one, if anyone ever has any of these problems, I know y'all aren't going to go to the doctor, and two, a lot of patients don't really think about it either all that much, right? There's only like significant hypochondriacs who are really worried about, maybe a little bloodshot eye, not thinking that it could be a worse thing. Papilledema is swelling of the optic disc, which is in the back of the eye, that is caused by elevated intracranial pressure. Pain when they wake up, in their eyes, in their head, any sort of increase in pressure, right? Coughing causes an increase in pressure in not only the intracranial or intrathoracic cavity, but as well as in the head. I think, as anyone who's ever had a bad headache and had a coughing fit knows. We are never going to necessarily see what this looks like, because this image is what the ophthalmologists use when they look into the eyeball. And we don't really do that on the ambulance, because what are we going to do for a patient with papilledema? We're going to go to the hospital. One thing that you should kind of have an idea of is a retinal detachment. So basically the retina sits inside of the eye, sort of like the placenta sits inside the uterus, right? So it's kind of embedded into the back of the eye with vasculature, etc. So if something happens, usually it's like a direct trauma to the eye. Sometimes it can be completely spontaneous, but the retina detaches from that vascular bed and it starts to be deprived of oxygen and nutrients. So the patient might say that they see like a floater, or they see like there's something in their field of vision, and that's the retina floating in front of their lens. So it's kind of inside the eye, blocking their vision. If it's not dealt with promptly, sort of like a placenta abruption, that part of the whole retina can die. So this is one of those things where you really do need to promptly transport to the hospital. Another thing that we might see, very rare, is a retinal vascular occlusion, right? It's a tiny stroke to the eye, or a retinal vein occlusion, where the blood cannot no longer drain out of the eye, so it ends up leaking into the eye itself. So the eye might look very red and very swollen. Again, not a lot that we're going to be able to do for either of these situations other than transport rapidly to the hospital. A little more information on a occluded central retinal vein. This is very commonly seen in a number of, your standard comorbid patients, your diabetes, hypertension, anybody who has a bleeding disorders like excessive clotting. Patients might experience what we call floaters in their field of vision, which is basically the blood getting into the aqueous humor inside the eye and creating distortions to the field of vision. Transport. A little more on the retinal artery occlusion is just a stroke of the eye, right? So painless loss of vision in one eye, similarly to when we have a stroke in the brain, if it's not dealt with within about 4 hours, the vision will be lost completely, right? Because the eye can withstand a little bit of hypoxia. It might be seen in a number of different situations, usually the same situations that you would see cause a stroke, right? So thrombosis, DVT, patients with AFib, high blood pressure, migraines, severe migraines, right? So migraines are associated with spasms of the vasculature in the brain, which is why they're so intense. So if you have a spasm of the retinal artery, you're going to end up with the same kind of situation, even though there's not a necessarily a blood clot in the artery itself. Oh, too much enthusiasm. Orbital cellulitis, okay, just like any other cellulitis, it is a infection of the tissue, right? It just happens to happen around the eyeball. Usually it's spread from a sinus infection that kind of wanders off to the eye. Because remember, everything's sort of attached. I think people forget that. That everything is kind of like the ears and your nose and your eyes are all attached through various canals and air spaces within your head. So this is why untreated sinus infections can become very, very dangerous, because not only can they wander to your ears, but they can wander to the brain as well, depending on how bad the infection itself is. If not treated properly, it can cause a number of different issues, meningitis for one, and hearing loss, right? Because again, everything's attached, so it could cause damage to those little tiny bones inside the ear. Speaking of ears, here we are in ears. Foreign bodies, toddlers love putting stuff in their ears and their nose. Most of the time it's not a super emergency. The person who's really panicking is probably mom, especially if it's her first kid and it's the first time she's dealing with an M&M in a nose or an ear. Sometimes they don't even notice if there is something in fact in their ear. There was an episode of like Tales from the ER or something where a guy had fallen into like this catatonic state where he was just screaming because a roach had crawled into his ear and was trying to chew through his eardrum. And every time the roach bit into his eardrum, he would screech in pain. So, fun little story there. Happens more than you think. What? Was this recently? Who let you have a Swiss Army knife as a kid if you're sticking marbles up your nose? Lord Almighty. A very, very, very special individual. Anyway, impacted earwax can cause significant hearing loss. I don't know if anyone's seen all those wild like ear wax removal when like they do the little candle things or whatever. If you want a nice rabbit hole to fall down, feel free to look at the earwax removal videos. They're up there with my Dr. Pimple Popper. It's just like weird things that you can watch for hours that you're like, why am I so fascinated? It can be very itchy because the ears tends to hold onto bacteria, which can then like grow and be very excited about life. So it's a possibility. It should be in your differential diagnosis for slow onset hearing loss if that's a complaint you end up dealing with. One that you're going to probably deal with more commonly is labyrinthitis. It's a swelling or irritation inside the labyrinth of the ear, which is the part of the ear that gives you your sense of balance. So if there's irritation there, you will have a patient who's potentially very dizzy with vertigo and might also have some level of hearing loss or tinnitus. Usually it's an upper respiratory infection that has wandered off to the ear. This whole section in... Hold on, let me remember how to do this now. There it is. Oh no. Okay. Curses. I didn't want to be here. Never mind. All right, so this whole section in here, there's little tiny hairs inside the cochlea and the vestibular duct, that whole area in there. There's little tiny hairs that have little tiny crystals on the top of them. And as you move your head, those little tiny hairs with those little tiny crystals move. And it kind of gives you what we call proprioception, which is your body's concept of location, of where it is in space. Okay, so if you have any sort of inflammation to this area, those little tiny hairs aren't necessarily going to be able to move appropriately, which means that your sense of place is also screwed up. So, that's where that sense of vertigo happens. Also can happen after trauma. So if those little tiny crystals get knocked off of the top of those little tiny hairs, they start to rumble around inside that duct like tumbleweeds. Okay, so you'll move your head and all the little hairs will go and you're like, all right, cool, I moved my head. And then you have this like boulder of a tiny crystal going through and like hitting all of the little tiny hairs, making you feel like you're still moving. It's a pretty wild sensation because, like, again, it's very dizzying and it really kind of screws with the way that people can sense their position. Those little tiny crystals do tend to be absorbed after a while, but it could be months of kind of being disconcerted of where they are in space. Meniere's disease is another one that you will hear a lot about. It is irreversible, and it is caused to a change in the fluid volume inside of that labyrinth inside the ear. Not only can it cause really bad vertigo because the fluid is in there and causing significant pressure, it also can cause hearing loss because you have to remember that now noise can't be transmitted through all of that fluid, so that it's not getting to the nerve where they can get to the brain well. It can be caused by infection. It can be caused by certain medications. It's one of those things that just kind of pops up every once in a while, like an episode of House, where like all of a sudden it's a really weird kind of diagnosis that you weren't expecting. Personally, I don't think I've ever had a patient who had Meniere's disease. And again, there's not a lot that we are going to do except for recognize and understand really what it is, because it might be that the patient's calling for dizziness or vertigo secondary to a Meniere's disease. May or may not be diagnosed. Positional vertigo, right? We talked about this already. So here's the little tiny crystals becoming dislodged. It's super common right after a trauma. Okay, so here you have what they call them otoliths. Liths meaning stone, and oh my goodness, and auto meaning ear. So all of these little perception, these little green guys on the bottom are your proprioception detectors, right? Because they're little tiny hairs, and there's the little tiny crystals that float in the membrane. So if those little crystals start bumping into the cells inappropriately of these microvilli, then you're not going to be able to understand. Your brain's going to have confused signals coming to it about where it is. So it's usually very benign. Usually those otoliths, the wandering otoliths, they're reabsorbed by the body and stop becoming such an issue. Otitis media, very common ear infection. Okay, there's a fluid or infection or something in between the eardrum and the inner ear. And the eustachian tube, which is, gives you drainage into your nose, is blocked. It's either, blocked or it's inflamed as well. So the fluid builds up, it cannot drain, and it causes a lot of pressure in the eardrum. That can be very, very painful, especially in young children, and can actually lead to a burst eardrum if the pressure is not relieved at a certain point. Very commonly eardrum issues happen when pressure changes in air cabins, right? In airplane cabins. Little kids, right, don't necessarily have the ability to communicate appropriately and tell you what's going on. So one of the most common signs of a kid having an ear infection is that they pull on their ear. Because I don't know if you've ever done it, especially if you're in an airplane. If you pull on your earlobe, it actually alters the pressure inside of your ear. It releases some of that pressure. So ear pulling is a child trying to alleviate the pressure in their ear. And speaking of ruptured eardrums, it could be caused by trauma. It could be caused by infection. Sometimes there's like a little blood that comes out of the ear. Sometimes it heals, sometimes it doesn't, but there would definitely be an impact of hearing loss brought to you by a perforated tympanic membrane. Q-tips are frequently a cause of tympanic membrane. Supposedly you're not supposed to use those in your ears. I call shenanigans, but either way, that's what a perforated eardrum looks like. Questions, thoughts, concerns? Sweet. To the nose. Brianna brought this to us today. Epistaxis. So epistaxis is an acute hemorrhage from one of the nostrils or both of the nostrils. It usually originates from the anterior nasal septum, secondary to nose picking. Okay, especially in children and dementia patients. Remember, dementia patients kind of do that backwards regression into childhood behaviors, so they tend to pick their nose as well. Or as one home health aide once put it, she's a chronic nose picker, and I'm like, that's hilarious. It's just such a weird little phrase. Epistaxis can be pretty self-controlled, unless, of course, either A, an artery is involved, or B, the patient is on blood thinners. I had a patient a few years ago who had a spontaneous nosebleed and happened to be on Coumadin, and he bled so much that he actually was significantly hypotensive. So just because it comes over as an epistaxis doesn't necessarily mean that it's going to be easy run-of-the-mill. Hold on, stop share for a second. So blood is extremely irritating, okay? So what people do is they say, oh, lean back. Don't lean back. Because when you lean back, it goes into the oropharynx and the nasopharynx, and people tend to swallow it, and then then they're nauseous and they want to throw up. So when you're dealing with an epistaxis, ice packs are super helpful. There's an artery that runs to the anterior nasal septum. The artery runs right through here in that like under bit. So if you have the patient put a finger here and push up, and then have a finger here at the bridge of the nose, right where like the soft bit ends and that hard spot begins, there's another artery there. So if they push there and push there, the epistaxis is usually very well controlled very quickly. Okay, that's ideal. I've seen people do some wild things try and help control nosebleeds. That's the easiest way to do it. Throw a 4x4 on there, and give some pressure and call it a day. All right. That was my sidebar for today. Back to noses. So here's as I said before, here's that artery right here. And here's that plexus where a number of the different arteries sort of come through. This is that spot where the soft tissue ends and that hard part of your nose begins. Basilar skull fractures, right? So if you are looking, come on, give me my little annotation pen. Kind of right here. Okay. Patients who experience a basilar skull fracture, they might have a lot of bleeding from one of these arteries because it tends to be severed, okay? Because it pops right through, down through that bone. So if that bone is broken, then it might end up with a bit of bleeding from that. This is also one of those reasons why we don't put an NPA in a patient with a suspected, skull fracture, because you're going to end up shooting it, right up into this area, and you're going to cause them a lot of other issues that they really didn't need because they already have a suspected skull fracture. Sticking things up your nose, okay? Might be uncomfortable, there might be some tearing, might impede how well a patient can breathe, specifically small children, right? Because small children are obligatory nose breathers. So they will feel that foreign body airway obstruction in that nose significantly more intensely than an adult will, when an adult can kind of figure out, I just open my mouth and breathe well there. A lot of times, depending on how far up, that can be kind of taken out without too much issue at home by the parent. Sometimes it does need to have to be extracted. Rhinitis is the state of a runny nose. There's so many different things that cause a runny nose. We're not going to really, if you don't know what causes a runny nose by now, you're not a real adult. Sinusitis, on the other hand, is usually caused by an infection, okay? It's a sinus infection. Your sinuses run throughout your face, which is part of the reason why we can hold our heads up, because all of those empty air spaces actually provide us a little less weight when it comes to how heavy our skull is. It also allows us to transmit noises, which is kind of cool, which is kind of increased how well we are able to do speech, right? As a human race, this is why we are, good at speech. Sinus pressure, right, can be felt above the eyes or under the eyes, depending on which sinus is involved. And again, that infection can kind of move wherever because it's all interconnected inside the head. So if you do have a patient who has a really bad sinus infection, they could be also experiencing ear pressure, conjunctivitis or something else to that effect. Let me get some coffee. Okay, so moving on down towards the mouth and throat. Dental health is extremely important for your cardiac health, which you wouldn't necessarily put two and two together, but they've done a number of studies that patients who have poor dental hygiene tend to experience really bad cardiac health as well, where they end up with endocarditis, pericarditis, or all sorts of other kind of not good infections of the heart. Go ahead. You're breaking up. I only heard part of that. Throw that in the chat. Yes. Yes, it can. Strep can travel to the heart. Almost any sort of infection of the oropharynx in the mouth can travel or anywhere in the body, but for some reason it just from the mouth goes right to the heart. It just beelines right there. The problem is it'll also go to the brain, right? So I don't know. I think dental abscesses are probably one of the most scary things to me, especially if it's in the upper jaw, because it's really close to the head, right? So that abscess starts to grow and grow, and that bacteria starts to get a little frisky. It's going to end up, to me, potentially right up into the brain. And it's happened, and it's got some, larger impacts that can really cause problems. Patients, and this is when you talk to a patient, you see, I think as humans, we kind of judge people by their teeth a little bit, especially in like first world countries where you're like, oh, like they are missing teeth, or they have kind of odd colors or shapes to their teeth that aren't normal. Because now as a medical professional, when you look at that, that's telling you a lot as well, right? Just because a patient might have stained teeth from smoking. So if they have stained teeth from smoking and they're complaining of difficulty breathing, that's a huge clue to you, right? That's like, okay, well, maybe they've got COPD. Okay, maybe they have lung cancer. Maybe there's something going on here that's associated with the other parts of their physical presentation that I'm looking at. Yeah, I think that's about it for that one. What else? Let's see. Pharyngitis and tonsillitis. Tonsils, right? There's this really awful video of them taking out tonsils in like Soviet Russia, and they just open the kid's mouth and rip their tonsils out and move them along, like in a line, like wild. A number of infections kind of hang out in the tonsils and in like the back of the throat there, right? It could be strep throat. It could be the common cold or flu. It might be coronavirus. Mononucleosis is actually kind of, it's why it's called a kissing disease, because that virus lives inside of the oral mucosa, so it can cause significant inflammation in the tonsils, right? So we talk about the tonsils and how, oh, they're kind of, we can take them out, it's no big deal. The tonsils are part of your lymphatic system, right? So they do a really good job of filtering the blood and everything that's kind of in that back of the throat area. Yes, they are very easily taken out because they can cause issues with swallowing and a number of other problems, like breathing issues for kids who have chronic tonsillitis, but they do serve a purpose. Most of the time, upper respiratory infections are caused by a virus, okay? Yes, it can be a bacteria here and there, but primarily, like 89% of the time, it is a virus. And this is part of the reason why we shouldn't be prescribing antibiotics to patients with upper respiratory infections. If they self-resolve within about 2 weeks, it's a virus. If it continues to linger, it's more likely to be bacterial. This one's fun. A peritonsillar abscess. This can cause not only significant swelling in the neck, but it can cause breathing difficulties. It can cause swallowing difficulties. It is one of the most common infections of the head and neck in adults and or children, especially for those who have had chronic tonsillitis, okay? So basically, that tonsil, or the area right behind the tonsil, or both sides, develops an abscess, right? So that pus starts to really develop and it becomes extremely swollen. And if you see in this picture, this is a straight-on shot, but you see his uvula is kind of making a beeline for the right side of his neck, right? Because you have that huge abscess in that left tonsil that's causing, almost like when you see a patient who has oh my gosh, attention pneumothorax. There you go. It's pushing everything off to one side. That abscess is pushing everything off to one side. So swallowing and breathing could become complicated by that level of infection in there. Ludwig angina is the only angina that you can get that doesn't involve your heart. I don't know why Ludwig named it angina. But it is cellulitis of the underside of the mouth, so like all of the tissues under the tongue, and sometimes also involving the parotid gland, which is the gland that produces spit, okay, or saliva. Usually, if there's some level of like a lower dental abscess or other tooth issues, it can cause that sort of level of swelling. And it can become bad enough that it actually will block the airway. Just not a good look, honestly. That needs to be treated. Epiglottitis is a bacterial infection that causes inflammation of the epiglottis, right? We talk about this very commonly with small children because they are the ones who are most significantly impacted by it because their airway is so much smaller and their epiglottis is so much larger. So if you already have a large epiglottis and then you swell it up a little bit more, that swelling is going to be significant, right? So the hallmark sign of epiglottitis is drooling, right? Because there's so much, it produces the inflammation, all of that fluid and edema, it causes extra drooling and the swallowing becomes difficult because of the sore throat and the enlarged epiglottis. Muffled voice is also another hallmark sign of epiglottitis, right? It sounds like they aren't able to speak clearly because that epiglottis, again, remember, is what's controlling the way that air flows out of your lungs. Laryngitis is a swelling and irritation of the vocal cords. Commonly viral, can also be caused by a level of trauma, okay, right? If there's some sort of swelling due to a traumatic hit to the neck, the anterior neck. Also can potentially be bacterial like strep, but most of the time it's viral. When you guys do airway, if you look at this picture here on the right of the normal larynx, this is pretty much, if you flip it upside down the other way, this is what you're going to be seeing when you guys start doing intubation. So let me pull up this little bad boy right here. Yellow. This one. All right, right, so right here, I don't like that. I don't like that at all. This right here, right, is the epiglottis. Okay. If you are using a Mac blade, this is what you'll see. You'll see all of this right here. Because where does the Mac blade go? Bueller? Yes, thank you. And the vallecula. The vallecula is kind of like over here-ish. Right there. Okay. And then you have your cartilage ring. Right here. And then you have your vocal cords. Okay. These white, these are your true vocal cords, right? That white portion is important to note because it's a good landmark for you. You are aiming to get the tube down the hole. If you are using a Miller blade, you will not necessarily see this ridge of the epiglottis because you're putting the blade kind of here-ish, okay? And you're holding the entire airway up. If there's any sort of occlusion or something like that, you might not be able to see this clearly. Roast beef tends to look very much like human tissue. Not that you needed to really have that image in your head this morning, but you're welcome. Anyway, all right, moving on. Oral candidiasis, thrush. It's a yeast infection of the mouth. Very, very commonly seen in nursing home patients who do not receive proper oral hygiene, okay? Very commonly seen in patients who have a trach and are on a vent because, again, poor oral hygiene. It happens occasionally in young children, diabetics, right? Because if you're diabetic, you're a little extra sugary. So the yeast is like, this is great. Just think of the yeast in your body as sort of like the same yeast that you make bread with. Same kind of general concept. So if you put yeast in warm water with sugar, it froths up, which looks very similar to this. Same kind of idea, okay? It's gross, kind of just gross looking. I'm pretty confident it doesn't exactly have a lovely flavor to it either. Inhaled corticosteroids can cause this as well because it just kind of increases the how well that yeast can habituate in that area. this is why after, like, if you have a patient who takes an inhaler regularly, who takes inhaled corticosteroids regularly, they're advised to, like, rinse their mouth out afterwards, because it helps prevent the thrush. Just, that requires some diflucan and maybe a good toothbrushing. TMJ, okay, very common. It's an issue with the temporomandibular joint, which is like right where your jaw connects to the top part of your skull. It's right in front of your ears if you want to palpate yourself to find out what that is. Basically, it can affect a lot of the ways that, as a human you work, because we chew and eat and swallow and then make facial expressions, and just kind of, function using that jaw and our mouths. Most of the time, the problem with TMJ is that it clicks, okay? The bone will sort of dislocate gently. In younger kids, like young teenagers, if they yawn too wide, they can dislocate that and won't be able to reclose their mouth. Not necessarily like life-threatening, but definitely uncomfortable and something that you might have to manage at one point or another. Okay. Questions, thoughts, concerns? Things that you should know, things that you might see, but things that you're probably not going to be, managing on an emergency status. That's the word I'm looking for. I'm having a rough Monday. I apologize. Chest pain, 12 lead shoulder ST elevations, bad strep throat. Wow, that's a really cool case study. Yep. Salivary stones are a problem. Tonsillar stones are also a thing. I don't know if anyone's ever experienced it, but like as you swallow, like food and particles can get stuck in the tonsils, and then they become tonsillar lifts, right? Because we call everything a lift because it's just way more medical. What? No, just what? No. Okay. But you can get tonsil stones. Also weird, gross, random. Your body just like makes little tiny pearls. It's like an oyster. It's like, what's this little piece of food that doesn't belong here? Let me put things on it. Cool. All right. So if no one has questions, I will remember to share my screen. Actually, I'm going to switch over first. Hold on. Okay. Bože. Ta-da. There we go. Okie dokie. What's up? Sure. Amazing. That right there is just an indicator of poor human skills. That makes me sad. Yeah, no, that's upsetting because it's not terribly difficult to make sure, and this is something that you're going to talk about when we get into geriatrics and we get into GEMS and stuff like that a little bit later. Actually, not that much later. We're moving through this class rather quickly, but treat people like a human. patients, especially elderly patients, have a lot of concerns, and they're very valid concerns. Like, who's going to feed my cat? Who is, am I ever going to get out of the hospital? I don't want to go to the hospital because I don't think I'll ever make it home. Hearing aids are important. Like, okay, now tell me if that patient had an LVAD. Were they just going to go to the hospital without his battery and his charger and all that other stuff? So why would you take a patient to the hospital without their hearing aids if they have no other way to communicate? So use a little common sense, I guess. Let's go with that. Let's use a little common sense and a little humanity to not be poor healthcare providers. Thank you for sharing. Sure. Okay. Yes. Yes. So if you are doing or working with a LifePak 15, and you do a 12 lead, the printout will give you a what the elevations are, like what the machine calculates elevations as. So sometimes you don't really need to even see that because you're like, oh no, that's an elevation. Sometimes it might be very, very subtle, like that 1 millimeter elevation that you're like, maybe not. And it kind of can give you some fuel if you're calling for medical control for some sort of order for like a STEMI transport, that you'd be like, oh, well, I see this, and the EKG is also confirming that there is a 1 millimeter elevation, even though it's hard to see. So it can provide you a lot of extra fuel if you are really concerned that the patient is having a STEMI and they're not, playing nicely in your sandbox. I think that's part of it. I think that's part of the algorithm. Yeah, because there's sometimes you'll have a patient who has like really like a bundle branch block, and it'll trigger an acute MI. And sometimes there's just other like kind of random things that it will be like acute MI suspected, and you're looking at it going, what are you looking at? Like it doesn't look like an MI to you. And sometimes it's not. It's like pericarditis, for example. If you have global elevations, it's going to say, acute MI suspected, and it might say, pericarditis, potential pericarditis, or something like that. But the machine only has, a certain skill set. It's not always 100% accurate. Mm-hmm. Mm-hmm. Okay. Of course. Mm-hmm. Mm-hmm. So it might have also been early repolarization. I don't know if you actually got a... Yeah, so the morphology of the EKG looks a little bit different when it's early repolarization versus an actual elevation. I will pull that up actually, let me see if I can pull it up now. Let me find it. Also, if I pass out, it's because it's 80 degrees in my office. Don't mind me. I might actually even just give this whole article to you. I'm going to see if I can find this article because it actually looks like it might be good. So, early repolarization. Let me get a little. What color should we do? That's a good color. So, you see how you have the elevation here, and I think this is also going to help a little bit in terms of the J point, right? We talked about that. Here's your J point, right? And here's your J. You have a J wave. Okay, so instead of it being like, hey, we're going to go right into this T wave, it gives you like a little squiggle, which is usually an indicator of early repolarization. Sometimes it also might just, remember we talked about the sad face versus the happy face in regards, that's kind of here too, right? So you have a very asymmetrical kind of smiley face here. Here it's a little, it's sloped a little differently. I don't know if you can really kind of see. I'm trying to, I think that's really about in terms of the early repolarization. Yeah. Or, no, this is, yeah. Or, because sometimes you can't even see the J wave too. Sometimes it kind of gets smushed right into the QRS complex. But yeah, it's a very, hold on, let me see if I get another picture that's useful. So you might have, you know, where the whole isoelectric line is elevated. Or, you know, usually you'll see that little kind of squiggle right beforehand. Okay, but yeah, especially it's very common. Early repolarization is very common in younger patients. So that's not to say that a younger patient cannot have an ST elevation issue, like MI. But if you have somebody who's like, I was having some chest pain, it went away, it could have been triggered by probably like anxiety or grief or stuff like that, because that's very, very common. Very good question, though. Cool. No, thank you. All right, let's try this again. Any other question before we go on to respiratory curses? There we go. Double curses. Get out of here. Screen sharing. There we go. All right. Okay, I will look at it. No problem. So in case y'all forgot what your airway looks like, here's your airway again, which I think you guys are going to be doing intubation stuff soon. So this is, you know, it's well timed, despite the fact that you should have been doing intubation, you know, when we did that airway portion. So again, we split the upper airway and lower airway, kind of at the level of the larynx, right, the vocal cords. We don't like when things go past the vocal cords. It makes our lungs very sad. Makes our medics very happy because we try to McGill's things. Other than that, you know, quick, brief review: external versus internal respiration. External respiration is between the alveoli and the external environment, while internal respiration is between blood cells coming from the lungs and this tissue, the end tissue that it's dealing with. Various risk factors for respiratory diseases, right? So genetics, asthma, they think has a level of genetic factors, as just cancer, obstructive lung diseases, things like cystic fibrosis, right? All genetic. Cardiac disorders can cause a number of different issues, such as pulmonary embolism or edema. If you have underlying issues such as asthma, stress can trigger those things. And then extrinsic environmental things like smoking, pollutants. One of my friends from elementary school lived across the street from what was used to be a garbage dump. Okay, they capped it and they moved on. But everyone in that neighborhood, on that side of the neighborhood, ended up with like a lot of really weird diseases. Like there were a lot of cancers. She ended up with really severe asthma, even though she had never previously been diagnosed with asthma, right? Like all of a sudden she's like in the 5th grade and on hearty doses of prednisone to control it. So environmental pollutants are a huge factor in not only respiratory diseases, but cardiac and cancer, et cetera, et cetera. Even you look at Long Island, people who live on the North Shore tend to be dealing with like clusters of breast cancer and stuff more than other parts of Long Island. There's just these little hot spots that the environment is causing issues, which is just wild and terrifying all at the same time. So there's a number of things that affect how your respiration works. Starting off with your acid-base balance, right? We're going to start here on the bottom. Your body uses the respiratory rate and depth to kind of balance any sort of alteration in acid and base. So if you are you have too much acid in your system, you'll hyperventilate. If you have too much base in your system, you'll hypoventilate. Your body's very good at picking up those like very subtle differences in your bloodstream. And that's also kind of tied into the control of breathing by your central nervous system. This is why we see respiratory derangements in patients who have head trauma, right? Because the central nervous system isn't working properly. So we see patients who have, the irregular breathing that you see in Beck's triad. And then you need to make sure that if the chest wall is in appropriate shape, right? So if you have broken ribs, patient's not going to have the greatest chest excursion and their respirations are going to be off. If they're experiencing, if their diaphragm has been damaged or their intercostal muscles are no longer being innervated, right? These are a number of different things that can cause issues with the way that a patient is able to breathe. There's a bunch of different things that kind of cause issues with the pulmonary system and its ability to do what it's supposed to do. Your body does try to compensate based on, again, as the rate and depth, but it's not always successful. When it comes to respiratory emergencies, it's usually one or two of these issues. Either there's an issue with ventilation, there's an issue with perfusion, or there's an issue with diffusion, right? So either air's not getting in and out, blood's not going round and round, or oxygen cannot achieve external or internal respiration, right? So you might be going in and out, but it can't get to the tissues, right? It can't get to where it needs to be. So let's investigate. So in terms of ventilation issues, right, you need to ensure that the patient has appropriate neurological control, okay, right, that there's no damage to the brainstem or any sort of spinal cord injury that would prevent the nerves from doing what they're supposed to do, expanding the rib cage, inflating the lungs, that the diaphragm and intercostal muscles are working, right, that the upper airway is clear, okay, is there a tongue in the way, is there food, is in the airway, is there a Lego, right, or what's going on in terms of the upper airway that you can see, is the lower airway working, right? Is this a patient who their lungs are full of fluid from pulmonary edema, right? Are the alveoli intact? Is there a pneumothorax? Is there atelectasis secondary to drowning, right? Or a chemical inhale, right? There's a lot of different things that can damage the ventilation process that, it all kind of rolls up into a ball together that you might have to figure out. Various different issues, right? So anaphylaxis, angioedema, epiglottitis, trauma to the upper airway, foreign body airway obstruction. We talked about tonsillar inflammation already as well from the previous lecture, right? These are all things that can cause upper airway issues. Lower airway issues, the same thing, trauma, any sort of obstructive or restrictive lung disease like cystic fibrosis or asthma or COPD, airway edema, which again might be secondary to anaphylaxis, mucus plugs. Patients who are on trachs and vents tend to produce mucus plugs. Patients who have things like muscular dystrophy, right, might experience mucus plugs in the lower airways because they aren't able to cough effectively and get that junk out. Any sort of impairment of the central nervous system, like an overdose, stroke, trauma, TBI, and then chest wall impairment like pneumothorax disease, neuromuscular diseases, other inflammations, etc. Go. But what can we do? We can fix some of these things. Narcan, always good, if that is in fact what's going on. Otherwise, ventilatory support is a BLS skill, right? Can you create a good seal, and can you push air into the lungs? Can we fix internal respiration issues? Not necessarily. But can we put air into the lungs so that the body can try to use it? Absolutely. Can we remove a foreign body airway obstruction? Can we intubate a patient who might be going into severe anaphylaxis and their airways shutting down? Absolutely. We have plenty of options in our toolkit to manage ventilation. Here's a fun mnemonic to remember. It's really, really good as well if you are trying to troubleshoot not only an intubation, but a patient who might be on a vent if you're doing critical care or transport. Dope, right? Always the first thing you should check is the tube displaced, okay? Especially if you happen to have to carry this patient up, down a flight of steps, moving them into the ambulance, right? Also another thing that you should always double, triple check. Is the tube still in place? Do you still have good chest rise? Is the tube mark still at the same place as when you first inserted the tube? Is there an obstruction? Okay. Generally, we don't have necessarily kinks, but the patient can be biting down on the tube, right? Or they might have a mucus plug, or they might have aspirated, and now that you've secured their airway, there might be food or some other item at the end of the tube that's creating an issue. Suctioning, always very useful. Is there a pneumothorax? Okay. Do you have equal lung sounds on both sides? Do you have chest rise on both sides? Do you notice the trachea, diverting to one side or the other? Is your equipment working? I've seen some pretty funky tape jobs where the BVM is not necessarily attached to the connector, but it's still taped together. So you're ventilating, but you're not actually putting any oxygen into the patient. You're just kind of giving them a small, gentle breeze. Is your oxygen connected? Okay. If you're doing a vent transport, right? Is everything connected properly? Are the settings appropriate, et cetera, okay? This is very helpful for you when you start to move a little bit more into airway management. Gas exchange, right? Gas exchange, if you can put air in and out as much as you want, but if there's no diffusion of that oxygen into the bloodstream, you're not going to be successful in ventilating, right? You still need the respiration part of it. Is there a thickening to the capillary or the alveolar walls, right? Is there some sort of fluid or mucus in the area where it's preventing that oxygen and carbon dioxide from moving through? Cystic fibrosis, pulmonary edema, all of these things, right? Pulmonary fibrosis. All of these things can cause issues in moving that air from the lungs into the blood. Other issues that can contribute to diffusion issues. We talked about drowning already, pulmonary edema, acute lung injuries, blebs that are associated with COPD, right? Could cause a pneumothorax. Asbestosis. Have you been a victim of asbestosis? If so, you might have a diffusion problem. Inadequate oxygen in the ambient air, right? Or have you been buried alive? Are you struggling to breathe even though your lungs are working properly? That's probably because you don't have enough oxygen in the air to diffuse into your bloodstream. You can also probably call for a lawyer for that one also. ARDS, right? Acute respiratory dysfunction syndrome. That's a huge one. That's like the lungs just kind of require greater and greater PEEP pressures in order to stay open. It happens very frequently secondary to trauma and other insults. Pretty sure we're going to talk about that in a little bit as well. Most of the time you should focus on improving the gas exchange as best as you can, right? CPAP works wonders if that happens to be a fluid issue inside the lungs. But, there might be other issues going on but really all we can do to manage is to provide oxygenation, ventilation, and transport. Is there an issue with perfusion? This is not only just perfusion to the lungs, but it's also perfusion to the rest of the body, right? So, one, is the patient hypovolemic? If you don't have blood, you cannot transport oxygen. It just doesn't work. But the blood needs to also have enough hemoglobin, right? If you have, severe anemia, you can have all the blood in the world, but it's not going to be able to transport oxygen efficiently. So this is why anemic patients also often have, feel very short of breath. This is the problem, pulmonary capillary issues, right? Is there occlusions? This is the problem coronavirus, right? It was causing these little microclots, and people were having a really hard time breathing because those microclots were living inside the pulmonary capillaries. So if you can't get blood to around the alveoli, there's no gas exchange that's going to occur. How about even a pulmonary embolism, right? Where you can't get blood to the lung at all. It's going to cause some perfusion issues. Same thing as if you have, issues with getting that blood to the end organs. If just because you're pumping blood around and around doesn't mean that oxygen's getting to where it needs to be. And then on top of that is the heart pumping effectively, right? Patients with CHF or something like that might have a dual issue where the perfusion is weak and they also have edema in their lungs, so the diffusion is also weak. So these are the considerations that you kind of need to take into mind when you are evaluating your patient, that these are some of the problems that you might need to address. It's another little indication for you. In terms of management of your perfusion problems, right, you need to try to improve blood circulation. This might be something as simple as propping that patient's feet up, right? It might be bolstering their blood pressure a little bit with some IV fluids. You might need to give them pressors, right? These are all things that you might notice help a patient breathe better, even though it's not directly managing, ventilation. Respiratory failure is pretty deadly, can very rapidly progress into cardiac arrest as well as respiratory arrest. But there is an issue with both oxygenation and carbon dioxide elimination, okay? Or one or the other. Patients who are going into respiratory failure look tired, okay? They look like they're having a really difficult time breathing. But there's different types, right? So are they having a hard time getting oxygen in, right? Where their SpO2, it might be lower than 90. Not that we're going to be able to see what the PaO2 is. Are they having ventilatory issues, right? Where they're not able to breathe effectively? Is there pump failure where they can't get the carbon dioxide out because it's not, the blood's not moving around their body effectively? So there's a lot of different contributory factors that can really create a respiratory failure situation. Once the pH starts to go also, that's when you start to have a patient really start to spiral the drain, right? Because now they're hypoxic and now they're acidotic and they're just starting to not be compatible with life. a number of various things that can cause respiratory failure, okay? But it also, they kind of fall on two ends of the spectrum, where you have patients who are experiencing hypoxemia, right, where they don't have enough oxygen in their blood, or hypercapnia, where they have too much carbon dioxide as they breathe, okay? So patients who experience air trapping, like asthma and COPD, right, they're holding on to too much carbon dioxide, versus a patient who maybe has a pulmonary embolism who can't get oxygen into their bloodstream because of a lack of perfusion, okay? So that's kind of, if that makes sense, that's sort of how we split the root causes of respiratory failure. Yep, that's about it I got to say there. Is this child sick or not sick? Sick. What are some signs here that you would say that this kid is not looking well? Yes, alertness is lacking. Okay. Mom's holding him up. What else? Open mouth. That's a very good sign, right? Does he look a little flaccid? Yes. Little AMS, a little flaccid. Open mouth breathing, right? This is like, we would be tubing this kid. Okay, this kid does not look well. And this is stuff that you also see with adults too, is like the head goes back, the jaw goes slack, and they become AMS, and it just, you have to start to make a decision. Okay, this is the point where you need to recognize the pattern, and you need to make a decision. And there's going to be times you're going to walk into the room and go, that patient's getting tubed, right? I need to control that airway. And then there's times you're like, I think we can fix it. I think a little CPAP, maybe a little oxygen, and they'll perk right back up, right? But it's going to be a bigger clinical picture, right? So PVCs, we talk about PVCs a lot, right? That's one of the first arrhythmias that you see with hypoxia, okay? Tachycardia as well, right? So tachycardia paired with PVCs, like maybe that might just shift your decision to tube or not tube, okay? Patients who are extremely AMS can't, protect their own airway. If you're doing blow by end tidal, right, and it's starting to get higher and higher, that might be a sign that it's time for you to do something a little more aggressive, okay? And when you start going on your ride-alongs and your rotations, you're going to kind of fall into a groove of aggression. And not like a bad way, but like you need to know when to act and when to hold your cards, and be like, I think that this patient can sit for a second. And you'll start to kind of pick up on those things, and it's going to depend a lot on who you ride with as well, because there are definitely some medics who are a lot more cautious than others. Sort of like the medic that Joe was talking about, who didn't want to sedate the LSD guy or the acid trip. Other medics would have been like, oh no, he's gonna take a nap. Like, he's just gonna chill. Like, he needs it. He needs to relax. There's people who would be like, no, whatever, and they might not even tie him down. So there's a continuum of medics and how aggressive they are when it comes to treating patients. And I think you need to kind of, as you do your rotations, figure out where you fall on the continuum, and then embrace it, and then go from there. But these are some of the key things that you're going to need to recognize that a patient's going into respiratory failure, and you're going to need to act. Another little quick review on the acidosis basic issues, right? So metabolic acidosis and alkalosis is controlled or try to be corrected through respiratory means, right? So the respiratory rate might be increased or decreased depending on which side of the pH scale you're on, and vice versa. Respiratory acidosis and alkalosis is the body tries to correct it through metabolic means. So just kind of keep that in mind. Don't forget that when your pH goes down, your acid is going up. and it's an inverse relationship on that scale. Acid pace pops up on the state pretty regularly. So when you're dealing with your primary survey, right, this is your ABCs. We're going to determine and correct any sort of life-threatening issues. And this is some of the things that, like, you might want to be more aggressive about, right? You might want to, recognize from the door that this patient's going to need a lot more care. Maybe I should call for BLS for hands. Right, we already talked about AMS, severe cyanosis, any sort of stridor, pallor, 1 to 2 word dyspnea if they're even able to breathe at all, significant retractions, accessory muscle use, diaphoresis, tachycardia. You might actually have to, palpate for a pulse. You might not be able to tell that from the door, but, these are things that you want to take seriously in order to move quickly. What's the chief complaint, right? So respiratory issues might have a variety of chief complaints. It's not necessarily always going to be dyspnea, right? It might be chest pain. It might be fever. It might be a cough. Might be irretractable hiccups, for goodness sakes. Like, I've seen that before. But does the patient have any prior experience with the same symptoms? And what happened? What was the diagnosis? Did they say, last time I had this, it was an asthma exacerbation? Or was it last time when we had this, it was a heart attack, right? So what's the patient telling you, and what's the history of those symptoms? OPQRST, right? So what were you doing? Was this triggered by something that you knew? Is it a sudden onset or a gradual onset? What position do you find this patient in, right? Patients with significant respiratory issues usually prop themselves up so that they can breathe better. If it's not fully respiratory in nature, they might not be sitting up, or they might be so altered that they're unable to sit up. Is there difficulty in inhaling or exhaling? Because sometimes patients will be able to tell you that they recognize a difference. Is there any pain associated, right? Is it sharp? Is it dull? Is it sudden onset pain? Where is your pain, right? Point with one finger, because patients were like, over here, and give you a vast, Vanna White kind of display of where pain may or may not be. The severity, and the timing of it, right? When did it start? Did it start really bad and get better? Did it start okay and then became unmanageable? And what did you kind of do to fix the problem, right? Did you try to do anything? Did you take an inhaler? Did you take pain medication for, a previously diagnosed rib fracture that, might be causing you to not feel like you're breathing adequately? A lot of different questions that you can be asking. The most important question: have you ever been intubated? If a patient doesn't know what intubation is, ask them if someone's ever put a breathing tube down their throat to breathe for them. If they don't know what you mean by that either, it's pretty safe assumption that they have not been intubated before. This is a good thing. Unless, of course, you're sitting there going, well, today's the day. Most of the time, patients who have been intubated, specifically asthmatics and COPD patients, if they've been intubated previously, they'll be intubated again, okay? That's something you're definitely going to want to know, especially before you start rolling. Because if there's any doubt that you'll be able to get that patient to the hospital without intubating them, then you might need to sit on scene and either stabilize them a little bit or call for orders to intubate, okay? So, you don't want to be intubating, flying, 30, 40 miles an hour down the road, trying to get a tube in. It's not a good look. Pleuritic chest pain has a number of different, potential causes. Most of the time, I want to say, is caused by irritation due to coughing because of a viral infection or something, or persistent cough caused by a number of other issues. Could be pneumonia, viral infection, etc. Sometimes it's lung cancer, right? It might be the only sign that the patient's got lung cancer, that they're coughing. So if you do your full workup and the patient's like, yeah, I'm having chest pain and it's on the right side and it only hurts when I cough, these are some things that you might want to take into consideration. Other signs and symptoms, right? So if you have a patient who's got elevated pulse and elevated blood pressure, that is usually less ominous than bradycardia and hypotension because the body is still compensating, the body's still fighting. If you have a patient who states that they cannot breathe and they are bradycardic and they don't have a previous, history of bradycardia or, significant beta blocker usage, that's concerning, right? That's worrisome. That may be a patient who you're going to be tubing. Carpal pedal spasms are some of my favorites, right? So the patient will have that hyperventilation caused issues with their toes. They might not be able to feel their hands. They get that claw vibe. Head bobbing and pursed lip breathing is usually a sign of respiratory failure. Okay? That's when they're about to go down. They're getting too tired to keep themselves awake. That head bobbing is like that AMS, right? That I'm not able to stay awake and conscious well. JVD, never a good sign. Barrel chest, club fingers, right? This is a sign of a chronic respiratory issue. What color of their sputum, right? Is it normal for them? Or is it a new color? Is it indicative that they have an infection? Or is it indicative of a pulmonary edema, for example, right? We primarily use pulse ox and capnography to use as diagnostic testing. Peak flow meters, however, are totally different. Hold on 1 second. I have to go deal with the doorbell. Talk amongst yourselves. Right there, and the other one's inside. Sorry, I'm in the middle of a lecture. They came to fix my air conditioning. All right, sorry about that. All right, so diagnostic testing, various things that we use on the ambulance. Moving on. Cute little reminder of what end titles you might see. If you do happen to lose a waveform, right, it might be that the E2 tube is no longer connected, might have been dislodged, patient might have gone into cardiac arrest, as opposed to the other side where you have all of a sudden the end tidal starts spiking, that you might actually have ROSC in a cardiac arrest. The shark fin appearance, right, it would be indicative of an asthma or COPD patient. The hypoventilation versus hyperventilation, right? The frequency of the little boxes that you see on your waveforms. And now, for various pathologies, obstructive airway disease. We talked about this previously in our airway thing a little bit. So there's a triad of 3 different diseases that are usually caused by a number of different predisposing factors, such as smoking, pollution, other triggers, allergies, chronic bronchitis, emphysema, and asthma. Most of the time, as a patient starts to get older, specifically, they may have more than one of these diseases. It's not uncommon that a patient with asthma also develops chronic bronchitis, that a patient with asthma also ends up with emphysema later in life. Just unfortunately the way it happens. So chronic bronchitis is a little bit different than the other two, whereas it actually is due to excessive mucus production. The clinical diagnosis of chronic bronchitis is a productive cough most days for at least 3 months, for at least 2 years. So you have to have a cough for at least 3 months. Then that 3 months of cough has to last for 2 consecutive years without any other identified cause. That's clear as mud. So basically, if you cough for about 2 months with a lot of mucus, you probably have chronic bronchitis. Commonly, in terms of like what we deal with, is that there's a VQ mismatch, right? Because that mucus is preventing the airflow into the lungs, and on top of that, it's also filling the alveoli, preventing diffusion of oxygen into the bloodstream. Okay, so it causes low blood oxygen and high levels of carbon dioxide. There's also issues in terms of the frequent infections cause lung tissue scarring, and they also can dilate the bronchi so that you have less adequate control over the airway. Emphysema is the destruction of alveoli, right? So instead of having like a lot of alveoli at the end of the bronchial trees, you have one big old alveoli, which means less surface space, which means less diffusion. Also, these alveoli lose a lot of their elasticity, so they collapse. And once they collapse, they don't tend to open up again. Alternatively, if they don't collapse and there's just air trapping, then due to the loss of elasticity, then that oxygen just stays there, right? And that's when you end up with a patient with the barrel chest, where they are having a hard time literally deflating their lungs because there's just not enough elastic tissue to push it out in that passive mode that we do. There's also, because of that reduced surface area, that's where your VQ mismatch comes from. There's increased resistance due to that larger space. And blebs start to kind of develop, where the alveoli, because they're so stretched, they end up kind of bursting. So you may have a patient who has emphysema who ends up with a pneumothorax due to their lung just bursting on its own. Oh my goodness, what is with everybody in the doorbell today? Hang on 1 second, guys, I'm sorry. No, it got zapped. All right, they're really going to fix my air conditioning, I promised now. So, the differences here, we have chronic bronchitis versus emphysema, right, where you have the blue bloaters versus the pink puffers. Usually emphysema patients are like a little older, thinner. I don't know, I think there's plenty of patients who have chronic bronchitis who aren't necessarily overweight, but their blood there's elevated hemoglobin in their blood because they're trying really hard they're compensating. Same thing with kind of emphysema to a certain extent, where they might have, increased blood polycythemia, which puts both patients at a risk for increased clots because now you have just thicker blood. Never withhold oxygen therapy, okay? Because I know this is like a myth that has been spread through EMS, that if you put a patient who has COPD or is working on hypoxic drive on oxygen, that you're going to reduce their respiratory drive. It's not true. And in a emergency setting in particular, if you have a patient who is experiencing significant respiratory distress, there's no reason to not give them oxygen, okay? It's the switch to hypoxic drive is kind of takes a few years, as the CO2 is no longer an accurate way for the brain to determine if the body needs oxygen or not. So it's just it's good practice to treat your patient, right? If the patient says, I have some emphysema, this, that, the other, and they're sitting there at 85 on room air, and they're like, no, I'm not having any difficulty breathing, then, maybe a little nasal cannula. That's not going to hurt them. But if you have a patient who's, and has emphysema and they're really struggling to breathe, there's no reason to not give them a non-rebreather. These are our traditional emergency meds that we use for our respiratory distress patients who have emphysema, asthma, or chronic bronchitis. Albuterol will relieve the bronchospasm as well as the ipratropium. They work down different nervous pathways. The Solumedrol will reduce mucus production, as will the ipratropium. And then overall inflammation is being reduced by the Solumedrol, or dexamethasone, depending on where you're working. Asthma is traditionally like an overreactive airway, right? So a number of different triggers can cause a patient to have an asthma attack, and most asthmatics are familiar with what their triggers are. It can become significantly worse, and like sometimes patients might not even notice that they are having an asthma attack. It might just be like a little cough, right? But it will progress to be worse and worse. And if they don't get any relief from their inhaler, that's usually when they call you. It's a two-prong approach. So first, the bronchial smooth muscles start to constrict, and then there is an influx of mucus caused by the asthma. So that's why we give Solumedrol in managing asthma, to reduce that mucus influx. There's also inflammatory changes, right, which contributes to that mucus production. As the airways constrict, it increases airflow resistance, so it makes it harder for patients to get a breath in, and then also hard for them to get a breath out, okay? A lot of different issues are surrounding asthma, right? If a patient doesn't treat their asthma, they will most commonly die due to asphyxia. Other issues, they might need, they might lose an entire lobe of their lung to atelectasis, as the airflow is not able to get down there and it collapses. Tension pneumos are popular. Pneumonia, because of the fact that you have this mucus production, and mucus is a really good spot for bacteria to live in, so they might deal with frequent pneumonias. In asthma, as opposed to chronic bronchitis and emphysema, we also can give the patients magnesium and epinephrine. That's sort of changing in the collaborative protocols in some regions, where you can give magnesium and epinephrine no matter what respiratory disease the patient might have as an underlying issue. Magnesium is thought to be a muscle relaxant, and epinephrine is going to work directly against the airway constriction, right? Because epinephrine dilates everything. Epinephrine also tends to give patients a little bit of the jitters, so if that's not uncommon. It's highly recommended that patients who are dealing with a respiratory issue like asthma or chronic bronchitis or emphysema, some IV fluids are usually helpful. One, it can thin out the mucus by not allowing it to become thick and concrete-like inside the lungs. And two, a lot of patients don't really necessarily realize that they are struggling to breathe. So that hyperventilation can cause a pretty significant dehydration. You don't really realize how much fluid that you lose just by breathing, especially when that work of breathing increases significantly. Status asthmaticus is really serious, okay? Patients die. You need to recognize this right away. Repeated doses of bronchodilators do not work. This is something where you need to be extremely aggressive, okay? Patient might be AMS, patient might be in respiratory failure. They might, be completely unable to communicate. There is no air moving in or out. Okay, it's just a stalemate because of the level of constriction inside the chest. Epinephrine is like your first go-to treatment because patients aren't going to be able to get a bronchodilator in, right? So you need to move to the other side of treatment where you're putting the medication like right into their bloodstream. You might need to intubate the patient. You might be able to relieve some of the restriction by forcefully ventilating the patient to get some level of oxygen in and some of that carbon dioxide out. If you think that you have a patient who's dealing with status asthmaticus, don't doubt yourself, because if you do doubt your treatment or your treatment and your diagnosis, that patient could die. Okay, so it's especially if they're on the younger side, they can handle aggressive treatment. Sometimes you will have a patient who is wheezing, who is not having an asthma attack, okay? There's plenty of other things that can cause airway edema or airway constriction or airway blockage that can also create some level of wheezing, okay? Fluid in the lungs caused by heart failure, or we call it cardiac wheeze, can create an asthma-like wheeze. A pneumothorax, pulmonary embolisms, right? That little old Lego that's in the airway of a small child could be creating an asthma-like wheeze. This is why it's important to do a good and thorough physical exam and get a history of like what's going on with the patient, okay? Pneumonia is one of the most deadly diseases in the world, actually, which is kind of wild, right? We don't think of pneumonia. Elderly patients are very frequently diagnosed with pneumonia, and it very frequently kills them. Because most of the time when older people, they don't notice, right? They don't necessarily notice right away that they're having a hard time breathing, or, you know, there's no cough associated with it because they're, you know, their mechanisms have kind of become dulled because of age. Anything that gets into the lungs that doesn't belong there can create pneumonia, all right? This is especially with aspiration pneumonias, right? Depending on what infectious process may be causing it, it also can be very, very infectious. Usually you have patients with like the productive cough and a fever, but there's plenty of older patients who also don't present with that because, again, their compensatory mechanisms are no longer as strong. The VQ mismatch that we see in pneumonia is usually caused by the purulent infectious matter that's consolidating inside the alveoli, okay? Sometimes patients, I see this a lot with patients in geriatric patients, that they will have pneumonia secondary to a UTI, okay? And that usually means that they're septic. These patients require fluid resuscitation. It's not uncommon to, you know, need to really kind of manage this patient with not just fluids, but you can manage them with an albuterol treatment and maybe even some Solu-Medrol, okay? These are all things that you have to consider when you're looking at your patient. Influenza virus number 1 is usually the cause of viral pneumonia, though RSV is the cause in children. Just because you have viral pneumonia doesn't mean that you're not going to get bacterial pneumonia too. There is a vaccine for pneumonias, the bacterial ends of Streptococcus pneumonia. I think it's Numar 13 or something. They recommend that patients, older patients, do get the vaccination for it to reduce their risk, especially, you know, as you get older, the risk of being in a nursing home increases, right? Aspiration pneumonia is anything that doesn't belong in a lung, okay? But that can kill you. So stomach contents, toxic materials, food, lots of different problems that can be caused by aspiration pneumonia. Patients who overdose on narcotics very commonly end up with aspiration pneumonia. So it's, you know, important, again, that when you do happen to maybe wake up a patient with Narcan, if they're trying to RMA, you need to either, 1, you need to make them aware of the fact that they may have aspiration pneumonia, and 2, you need to make sure, if you can, that you do a high quality patient assessment and get good lung sounds, okay? Much like any other respiratory issue, right, we're going to make sure that the airway is supported and ventilation is supported appropriately. IV fluids, I'm a huge proponent of IV fluids in respiratory concerns because patients, again, are commonly dehydrated at baseline, even on a good day, and then they start breathing hard and they are even more dehydrated. So they become, that mucus and infectious consolidation in the lungs gets very thick, and it becomes very challenging for them to cough and get it out of their system, which makes it really hard for them to breathe. Acute respiratory distress syndrome, ARDS. This can be caused by acute or direct or indirect lung injury, okay? And the lung injury can be caused by a variety of things, including coronavirus, other infectious issues, okay? diabetic ketoacidosis, transfusions, sepsis, drowning. Almost anything can cause acute respiratory distress syndrome. But the lungs become highly inflamed, and then the alveolar capillary bed, like the capillary bed around the alveolar space, becomes wider, so it's harder for the oxygen to diffuse into the bloodstream. In addition to that increased space between the alveoli and the capillary bed, the capillaries also become kind of leaky, okay? And then as they get leaky, there's that fluid in between, and they have patients where they have wet, heavy lungs, okay? It's a very deadly syndrome, okay, if it's allowed to progress. Even if it's not, even if there's aggressive medical treatment for it, it does require increased levels of PEEP. So the patient might be on a CPAP or BiPAP machine in order to keep their lungs open. They might be intubated on very high levels of PEEP just to keep those lungs open, and push that fluid out and try to reduce the space in between the alveoli walls and the capillary beds. And it can happen to anybody, even patients who had previously healthy lungs. Again, a lot of different things that we need to kind of consider. PEEP, as opposed to just high levels of oxygen, using different respiratory rates, that are adequate for the patient, diuretics in combination with fluid replacement to kind of flush out the system. A lot of the management that for ARDS is done in hospital because it does occur over a period of time. You may experience a patient who is going into ARDS after having a major operation or something, and you're not necessarily going to be able to make that full diagnosis of that's what is happening, so you're going to manage that patient to the best of your ability, right? So you're going to make sure that you adequately ventilate them, okay, and that you monitor them appropriately. Pulmonary embolism, I think we're all pretty familiar with this. Usually the first sign and symptom of a pulmonary embolism is that you've dropped dead. It's caused by a clot that has wandered up, usually from the legs, and gone straight into the lungs, and prevents blood flow into the lungs. So you can breathe well, but the oxygen isn't getting out of the lungs, okay? So the air is going in and out, but the blood's not going round and round inside the lung itself. So this is usually what causes it. It could also, other than blood clot, it could be amniotic fluid, it could be a piece of bone if you had a patient who had fat or bone, if you had a patient who had significant trauma injury recently. This is part of the reason that we don't use IV catheters more than once, because if you happen to shear a little piece of that plastic, you could give that patient a pulmonary embolism. Again, this is the wrong information. There you go. You can have effectively ventilated lungs, right? The chest rise is good, your oxygen levels set appropriately, but you're not going to be able to correct that hypoxemia. Patient might have a rapid onset of shock, because now that the blood flow is being restricted to the lungs, the rest of the body tries to compensate, which is, unsuccessful because there's still this big old clot sitting in the lungs. The Virchow triad is the risk for pulmonary embolism. It's a patient who has a hypercoagulable state combined with a vessel injury, right? Maybe some level of trauma that's associated, and then combined with stasis, right? So if you have a patient scenario where you have a girl who smokes and is on birth control, who just broke her femur, and she's been on bed rest, who's suddenly complaining of difficulty breathing, it kind of checks off all the boxes for potential pulmonary embolism. So keep that in mind as you read through patient scenarios, because you'll see that pretty frequently. Some examples of your stasis, right? Extended travel, patients who have varicose veins, that are not managed can have a high risk of pulmonary embolism. Bed rest, right? Patient who maybe had a C-section, right? They've had some sort of surgery and they're unable to move around as well. Long bone fractures, burns, all of these things put this patient at an increased risk for pulmonary embolism. Pregnancy, oral contraceptives create hypercoagulable states. Any of these issues, right? Cancer can cause pulmonary embolisms. Sickle cell is a huge problem as well. DVTs or known DVTs. Any of these problems can create the perfect storm for a pulmonary embolism. It's kind of cool if you look at the chest X-ray, you can see where the level of consolidation is, where the pulmonary embolism is occurring, because it's just creating damage in the lungs. Most of the time, if you have a patient who's dealing with pulmonary embolism, they might experience like a localized chest pain. That it might be also, related to a bloody cough or unusual anxiety. They might have rales or wheezing. Because as the blood flow is shunted away from the area that they can't pass, that patient will end up with a bit of a pulmonary effusion around the area. Usually it's kind of focal chest pain that doesn't necessarily radiate or is not reproducible, as opposed to other conditions that might cause chest pain. On the EKG, you may or may not see this pattern, but the pattern is S1Q3T3, because, that's just really trendy and easy to say. Usually this pattern is indicative of a potential pulmonary embolism because it shows the strain on the right side of the heart to pump blood to the lungs. So you'll end up with S waves in lead 1, Q waves in lead 3, and inverted T waves in lead 3. Okay, just something that you'll potentially see. I've seen it once or twice in patients with suspected pulmonary embolisms, but something very good to know. And here you'll see it again in the 12-lead format, where they have that big Q wave, inverted T waves in lead 3, and the slurry S waves in lead 1. Our biggest ability to manage pulmonary embolism is to ensure adequate oxygenation. You want to also make sure that you do your pulse ox and your cardiac monitoring, and tidal if possible, depending on which department you work for and if you have blow-by or if you've intubated the patient. This patient's going to most likely need surgery in order to remove a pulmonary embolism. Okay. URIs, or upper respiratory infections, are super common. We talked about this already a little bit. Bronchitis is very, very common. It could be caused by a common cold. You could have tonsillitis, sinusitis, any of these things. Most of the time, it is caused by a virus. Spontaneous pneumothorax, okay? When you are thinking about the patients you should suspect of having a spontaneous pneumo, it's usually the really tall, really skinny dudes, okay? With that long, narrow chest, because they're stretching out their lungs in unnatural tall people ways. But pneumothoraxes can also be just underlying weaknesses in the lungs or other issues or diseases. I had a lady once who we responded, she goes, "Oh no, I have a pneumothorax." And I was like, "Why are you so chill about this?" She goes, "Oh, I've had it before. I felt it was like a Monday morning." She goes, I felt it go on Saturday, and I thought it would get better." I'm like, "Okay." She goes, "Yeah, I really just don't want a chest tube." I'm like, "I don't blame you. That doesn't sound like fun at all." So, she was walking around fine. She had little diminished lung sounds on the one side because it wasn't a really significant pneumothorax. But, patients might just have a weakness in their lung wall that, will predispose them to having a spontaneous pneumo. Patients who have COPD as well. Older patients, especially during any sort of ventilatory mechanism. So if you're doing CPR on a patient and all of a sudden it gets really difficult to ventilate, it's a possibility that they have a spontaneous pneumo. A lot of the times it could be, again, focal chest pain with shortness of breath and decreased lung sounds, okay? That's usually your initial presentation. Tachycardia is also very common. You wouldn't necessarily expect your patient to be presenting with bradycardia. It just doesn't kind of work. So if you look at the cross where these two yellow lines meet, that is your ideal location to perform a decompression, a needle decompression. Sometimes, in the protocol, it says if you have a patient who is suspected tension pneumo, but it might be possible or required for you to decompress a patient even if they don't have, the signs of a tension pneumo where their, trachea is no longer midline, etc., etc. Because a trachea moving is a very late sign of a tension pneumo. You will always go above the rib in order to do decompression because all of the nerves and vasculature are below the rib. Okay, so it will hurt the patient less, and you have a less likelihood of creating a hemothorax if you insert the needle, which is a 14 gauge 2-inch minimum needle, over the top of the rib. Hyperventilation syndrome, or sometimes associated with anxiety, is really what causes the carpopedal spasms. Okay, it's usually very commonly caused with stress. Basically, the patient breathes so fast that they blow off too much acid and become alkalytic. I've seen patients who have hyperventilated themselves into blindness. Okay, because all that cerebral vascular constriction, they, reduced the blood flow into their eyes. They couldn't see. It was just wild, okay? Most of the time, patients do tend to kind of self-limit themselves in the level of hyperventilation that they can do. Basically, the body will turn itself off and they'll pass out if, that is the issue. Oh, here's that little chart again, in case you forgot the differences about, your acidosis and alkalosis. Your carpopedal spasms, here you go, right? So this patient is kind of giving you the hallmark symptom of hyperventilation syndrome. It's secondary to that acid-base issue, okay? That's what causes that distortion in the hands and feet. Most of the time you want to, but other than rule out the life threats, you want to make sure that you support the airway and try to calm the patient down. We unfortunately don't do the whole paper bag thing. The paper bag idea is that you're having them breathe back some of their carbon dioxide so that they can restore their acid-base balance. But you really need to just focus on psychological first aid, helping the patient calm down and refrain from hyperventilating. Lung cancer, bad. Smoking doesn't help. Primary lung cancer is either small cell or non-small cell, super specific. You can also have secondary lung cancer, which is caused by it's the metastasized from somewhere else. They have confirmed that smokers do have a 20 times higher chance of developing lung cancer than non-smokers. The smoke causes reversible changes to the cells within the airway. It replaces certain cell types with different cell types, and then they grow out of control, and this is really what causes the cancer, as well as all the toxins and other nonsense that's involved in a cigarette. A lot of the times you'll see patients who have lung cancer have really bad coughing issues. They might have sputum production. A lot of this stuff looks a lot like a regular old respiratory illnesses, and if they are not yet diagnosed, they might not even know that they have cancer. And much of the time, chemo can also be just as ravaging to the body as the cancer itself. Just make sure that you do pretty much everything else that you would do for the patient. You might have to support the airway and, circulation. You might have to give them some albuterol or something in order to reduce any sort of wheezing that might be there, and it might not work, right? So depending on what's causing the wheezing, albuterol might not help if it's caused by, the tumor. A lot of times you also will be taking care of the side effects of cancer treatments. Chemotherapy tends to leach calcium out of the bones. So the patients will present with hypocalcemia, right? Because they can no longer balance their calcium levels well. Radiation can cause patients to be very ill, very nauseous, very weak. So you might need to provide supportive care for those things. If you happen to intubate a patient who has lung cancer and you know that you're in and you know you're not too far back, that you're not right main stem, you might not get chest rise depending on where the tumor is located, okay? If the tumor is blocking like the bronchial tree or wrapped around, the bronchi, you might not get adequate chest rise on one side versus the other. So this is another point of where getting a good history, involving the family there, will help you out. I think that's it. Let's see. Yep, that's it. How are y'all doing? All right. Any questions? Yeah, I can hear you. Go ahead. So stridor tends to be something that you don't necessarily have to auscultate for. Like stridor is something that you can like hear from the door. You're like, oh, that's a problem. If you do have a patient who's maybe not breathing loud enough to give you the sound, yes, you can auscultate the throat. I think generally you don't even need to go that far. For most patients, you'd be like, oh no, that's stridor. You're welcome. Any other thoughts, concerns? I don't know. You might be. You should have fixed it yourself. Yes, but did you call IT? All right. Any other questions, guys? All right, cool. Please review your material. This is the next module exam is one that is going to have a lot of like varied information. So please make sure that you're kind of staying up to date with all of your work and reading. Okay? Other than that, I hope you all have a lovely day. You're welcome, and I'll see you guys next week.